Welcome for the second day, Train the Trainer course. Welcome, sir. So the first topic today is the lecture by Professor Kida. He's head and chief of gastroenterology and interventional US expert at Kitasato University, Japan. So the topic today is EUS-guided PD interventions, how I do it. Welcome, sir.
Yes, thank you.
Lecture.
Professor Kida,
Thank you
welcome.
for kind introduction, the chairman. And I will start. Okay.
We can't hear you.
Yes.
Yes, now we can hear you.
Yes. Okay. Can you look? Hello.
Yes, I can hear you, Professor Kida.
Yeah. Okay. Then thank you, kind invitation. My old friend, Dr. Vinay, Dhir, and it is a great honor to have a lecture in front of you. And unfortunately, by web. Today, I will talking about USPD. How do I it? Okay. This is COI. I have the two COI from Olympus. So at first, the indication of the USPD, the USPD is viable rescue procedure after failed ERCP in patient with obstructive pancreatic duct and inaccessible from the papilla.
Kida Sensei, we don't see your slides. We don't see your slides.
Pardon?
We are not seeing your slides.
So there's no slide?
No.
You have no slide?
No. Please share your presentation.
Can you see the
Not
slide?
yet. No.
Not yet. Really?
Flora, can you help Kida Sensei? Do you have his presentation?
I do not. Oh, there we go.
Now share presentation. Yes.
It's okay?
Yes, please make it full screen.
All right. So this is the indication of the USPD. The USPD is a viable rescue procedure after failed ERCP in patient with obstructive pancreatic duct and inaccessible from the papilla, such as chronic pancreatitis, pancreatitis, and the stenosis of the pancreatogegnostomy, and so on. Mainly the benign disease, less malignant indication. So the contraindication of the USPD is such as invisible pancreatic duct, non-dilated pancreatic duct, multifocal pancreatic duct structure, long distance from the GI tract, intervening large vessel in the puncturing route, marked thrombocytopenia, anticoagulant therapy, and so on. So the pre-procedure preparation of the USPD is imaging with MRT, CT, ERCP is helpful to establish the roadmap in the patient with the obstruction of the main pancreatic duct prior to the USPD, like this. There are several techniques, such as pancreatogastrostomy, and also the antegrade stenting, and the rendezvous technique with normal anatomy, and also with surgical altered anatomy with enteroscopy, like this. So, and also this is a techniques at first Donenai technique, pancreatico-enterostomy, including the pancreatic gastrostomy, duodenostomy, jejunostomy, transenteric antegrade pancreatic duct stenting across the papilla, gastrojejunal anastomosis, fistula and papilla or anastomosis. And also we have the rendezvous technique, retrograde pancreatic duct stenting across the papilla and retrograde pancreatic duct stenting across the anastomosis, like this. So this is a technique of the pancreatic gastroscopy, such as we call the transmural drainage. The puncture the MPD, insert the guide wire, put in the stent. There's a connection to the MPD and the gastric space. And this is a rendezvous technique, and with a normal anatomy. At first, puncture the MPD, put in the guide wire into the third portion of the duodenum. Then exchange the endoscope. We switch to the ERCP and insert the stent into the MPD. And also in the surgical altered anatomy patient, we can also perform the rendezvous technique with the enteroscopy, like this, after the insertion of the guide wire, and also that we insert the enteroscopy into the jejunum, anastomotic site, then catch the guide wire, then insert the MPD pancreatic duct stent. So this is a procedure of the MPD. At first, we puncture the MPD, dilate MPD, insert the guide wire. And also after inserting the guide wire, we dilate the fistula. And also finally, we insert the stenting, such as the plastic stent and metallic stent, and so on. This is a typical case of the EUS-PD with the pancreas stone after PPPD due to the pancreas cancer. He had a small pancreas stone obstructed in the MPD. The MPD dilated like this. So there is a needle, then 19 gauge and 22 gauge, EG shot, expect, sonotip, echo tip. But generally, we employ the 19 gauge at first. So this is a case of the EUS-PD. You can see the dilated MPD. We insert the 19 gauge. Then the puncture the MPD. After that, we fill the contrast into the MPD. How about the video by web? It's okay?
Yes, it is good.
Then you can see the dilated MPD by the X-ray. So in the literature, there are many guide wires used for the EUS-PD, such as the Vigilite 2, Jaguar, large focus, tracer, large focus, Metro, Pathfinder, Roadrunner, and so on. So generally, in our department, we mainly use the Vigilite 2 and the end selector. After puncture the MPD, now we negotiate the guide wire into the MPD. And generally, we would like to insert the guide wire as much as possible. So at least the third portion of the duodenum is better. So after the insertion of the guide wire, there are several dilation devices like this, the electrocautery, the cystogastrotome, and in Japan we have the fine 025, the very thinner electrocautery, and also the other mechanical dilator. Sphendular dilator is famous, and also in Japan we have the ES dilator, and also there is the balloon dilation, REN balloon. This is becoming popular because of there's almost no step to the guide wire. This is very useful balloon dilator. So generally mechanical dilator is used firstly, and secondary electrocautery device is secondary use when the mechanical dilator is failed. Like this. This is from the literature. There's the sphendular dilator, ES dilator, REN balloon, and sometimes the non-coaxial needle cut knife, and also the fine 025 cystogastrol set, and so on. So this is a study about the comparing the ES dilator versus cystogastrotome for the dilation. So, but according to in this literature, there is no significant difference between the mechanical dilator versus electrocautery dilator. But in general, at first we use the mechanical dilator first. Secondly, the electrocautery devices, such as fine 025. This is only 3 French, very thin dilator compared to the cystogastrotome. Today, we insert the ES dilator. Even the ES dilator, employ the ES dilator, it is very hard to insert into the pancreatic duct because of the pancreatic parenchyma is very hard compared to the bile duct, like this. So you have to keep the vertical position to the MPD, and we have to now insert the dilator into the MPD like this. So after dilation of the fistula, we plan to insert the stent. In the former age, we insert the straight stent, but nowadays Professor Takao Itoi invented the IT stent, named after him. IT means Itoi. Named after him. This is a special designed plastic stent, 7 French. Now we are planning to insert the IT stent into the MPD. IT stent, proximal side of IT stent is the pigtail. That is preventing the perforation of the gastric wall. So in the former age, we have the one case of the perforation of the MPD stomach stent pass through the gastric wall. Then insert the plastic IT stent into the MPD. Now we release deploy the IT stent into the stomach. Finally, we insert the IT stent into the MPD. This is the result of the USPD. So, and this is another case of the pancreatic duct stenosis due to the metastasis. This is Rendezvous technique. There is a metastatic region, and also the MPD is dilated. And also you can identify the dilated MPD. At first, we measure the distance Then we puncture the MPD by the 19 gauge EG shot 3. Feel the contrast into the MPD. After that, we insert the guide wire, then negotiate the guide wire, and we insert the guide wire into the duodenum as much as possible. Then we exchange the endoscope to the duodenoscope. Then generally we use a side-by-side technique. Don't catch the guide wire. We pass through that, and then we insert another guide wire into the MPD side by side. Then feel the contrast. And finally, we insert the plastic stent into the MPD. Like this. So there are a lot of the literature. According to the literature, the EUS-PD is more than the 32 studies, more than the 500 cases. Technical success is 78%, but the complication is quite high, 21%. So this is a comparison of the rendezvous technique, transgastric, transduodenum. There is no significant difference between these three techniques. But in general, the transgastric rendezvous technique is mostly employed. So management of the complication of the EUS-PD, the transpapillary stenting, such as antegrade drainage or rendezvous drainage, should be considered prior to the transmural drainage because of the complication rate is high. So you should plan to insert the antegrade drainage. That is better. That is no need to dilate the fistula by the cystogastotome or fine 025, and that reduces the complication, I think. So according to the this is a learning curve of the EUS-PD by the Tyberg. So according to this literature, after the 14 case of the EUS-PD, the total time of becoming the plateau after 40 cases, yes? So this is from the Korea, Donwak. They reported the experimental device with a metallic stent of the EUS-PD. The stent patency is around 180 days. This is and also the Donwak reported the long-term result of the metallic stent. So follow-up period of 27 months. The number of the procedure is 2 times, and the stent revision is 82%. Adverse event is still 21%. I believe this experimental metallic stent is still under investigation. We have to improve the metallic stent in the future. And troubleshooting of the EUS-PD. In case of the difficult puncture, such as the small MPD, in this case, we employ the 22 gauge with 0.018 guide wire, inches guide wire, fielder, named fielder Asahi Intex. This is very useful because the thinner needle can puncture the MPD more easily compared to the 90 gauge. And also in case of the surgically altered anatomy, there is a comparison of the double balloon ERCP versus EUS-PD. that this is not a randomized study, but this is a retrospective study. But the technical success is the balloon dilation is a little bit less than the EUS-PD, but the clinical success is of the same. The adverse event is high with EUS-PD. Then I think at the moment this selection is now the controversial. In our department, at first we try to the balloon endoscopy first. Then after that we employ the EUS-PD in our department. But this is up to the institution. So, and also this is a case of the failed endoscopic ERCP and also the rendezvous technique with the EUS-PD. This is a dilated MPD, but we failed the both technique. Then we employ the forward viewing echo endoscope. You know that this is a forward viewing echo endoscope. Then we try to do the EUS-guided pancreatic jejunostomy with the forward viewing echo. Now we are in front of the anastomosis site. We puncture the dilated MPD directly. Then feel the contrast. Insert the guide wire into the MPD. After that, we insert the catheter and also the dilated 025, find 025. Then finally, we insert the plastic stent into the MPD like this. Then this is the result of the EUS-PJS. Like this. And also this is a very instructive cases of the ERCP and the EUS-PD. So we puncture the we try the EUS-PD at first, so we can lead to the distal MPD. And at first, we constantly go into the pancreas head side, but the guide wire cannot pass. And then we try the ERCP, but however, the guide wire don't reach to the distal pancreas side. Then finally, we insert the pancreatic gastrostomy. Then after that, the second session, there is no connection anymore. Then finally, patient rejects the surgical operation. Then we try the more than nine now this year we tried 10 times. We exchange the stent every 3 or 4 months. So this is because of the this is benign disease. We have to repeat the EUS-PD forever in this case. So this is take-home message. EUS-PD, but these techniques should be done by the well-trained endosonographer. Complication is high for the EUS-PD. Most cases of the EUS-PD indication are benign. Therefore, before performing the procedure, you should think about the next treatment when failed. Otherwise, EUS-PD forever. Kind of bridging procedure. This is our staff. Thank you for your kind attention.
Thank you, Professor Kida. That was a fantastic, very, very instructive lecture from you as usual. Thank you very much. There are some questions from you from the audience. I will just read them out to you.
Yes.
So, Dr. Adil Ur Rahman is asking, what is your choice of dilator? Do you use a balloon or cautery dilator?
And at the moment, we employ the mechanical dilator named ES dilator.
Okay.
And this is first. And secondly, nowadays we employ the REM balloon. This is also useful. Finally, we tried these dilator. After that, we employ the fine 025 electrocautery. This is our strategy.
Okay. Okay. Another question is, what is the risk of pancreatitis after the procedure?
Pardon?
Risk of pancreatitis after the procedure.
And in our case, the most of indication is the chronic pancreatitis or pancreatitis. We have never experienced the pancreatitis. That maybe the pancreas is normal case. That is, we will have the pancreatitis, I think.
Okay. Okay. Dr. K.K. Raval is asking, what is the best site to puncture? How do you choose where to puncture?
And generally, we puncture the body and the tail. After puncture, we need a space for the guide wire. So therefore, we need a space that at least 4 or 5 centimeters for the guide wire, keeping the guide wire space. Sometimes we cannot pass the papilla. Then we insert the guide wire into that space that looks round. Then we keep the hard part of the guide wire. So therefore, I recommend you to puncture from the body and the tail. And but sometimes we puncture to the tail side. But in this case, we also need a space for the guide wire. Okay.
There is another question, lots of questions for you. So, if you are doing a pancreatogastrostomy, would you place the stent towards the head or towards the tail of the pancreas?
Yeah, optimally, we insert the plastic stent into to the head side and hopefully pass through the papilla. That is better.
Yeah. Then another question is, what complications are expected after the procedure?
Yeah. Of course, there is risk of the bleeding and leakage of the MPD, and we have some case of the shoot cyst after the puncture. So.
Bleeding and pancreatic juice leakage.
Yes, leakage.
Okay. Lots of people saying that it was a fantastic lecture. I agree. What are the current settings you use for cystotome if you are using a cystotome?
Fine 025 is very useful, but unfortunately, at the moment, fine 025 is only available in Japan. So
okay.
sorry. And I stimulate that company to export that electrocautery to the India and Thailand, other countries.
Okay. Another question is your preference of needle, 19 gauge or 22 gauge?
And at the moment, I prefer the 90 gauge if possible. But if I mentioned in my presentation, if the MPD is very small, I choose the 22 gauge.
Okay. So thank you, Professor Kida.
Yes.
It was fantastic, your lecture. It was very nice having you with us for this Train the Trainer program. And I am sure all our people, including me, have learned a lot from your lecture. Thank you very much.
My pleasure. Thank you very much. Enjoy.
Thank you.
Bye-bye. Next time.
Thank you, sir, for excellent talk. Now the next talk is on EUS-guided vascular interventions by Dr. Rajesh Puri. Yesterday, he has shown very nice, interesting cases. Today will be the lecture by him. He is the Director and Chief Interventional EUS Expert at Medanta Hospital, Gurgaon. Welcome, sir, for the talk.
Thank you, Priyanka. Is my slides are visible?
Yes, yes.
So thank you, Priyanka, for the kind introduction. I would like to thank AEG and Dr. Vinay Dhir for giving me the opportunity. And for next 30 minutes, the topic assigned to me is EUS-guided vascular intervention. As you know that EUS-guided vascular interventions are still in infancy. Very limited data is available, and what I'm going to talk is mainly related to the EUS in the management of gastric varices. Regarding the Dolophil lesions, hemorrhoids, pseudoaneurysm, only case reports are available, so that I'm not going to discuss, but I will be happy to answer if any questions come from the audience. So I'm going to discuss when you should use EUS in the management of varices, why and how you can use it. I have demonstrated yesterday the EUS guided coil and glue with the step-by-step manner in which I'm going to repeat today. So EUS in the portal hypertension, it has both diagnostic and therapeutic as well as experimental potential. It is used for assessment of the varices as well as confirmation of the obliteration, both for esophageal as well as gastric varices, as well as ectopic varices. There are few case reports where it is used as a therapy for the esophageal varices, where the perforators are targeted. A reasonable, decent amount of literature available about the role of EUS-guided management of the gastric varices. Case report in the form of ectopic varices, diagnosis of the choledochal varices, especially before doing the biliary intervention, or when the surgical colleagues want to do, then they always look at the choledochal varices. Experimental role in the tips as well as assessment of the portal hemodynamics. So why EUS angiotherapy is still in infancy? As I said, visualization and avoidance of the vessel within EUS is great. You know, till now, the role of EUS was to avoid the blood vessels while taking the FNAC, to know the vascular staging. But when we talk about the therapy, it is the extension of EUS-guided visualization and avoidance of vessel. But the problem is there is a limited studies, small number of patients, lack of dedicated devices, limited maneuverability of the current ingo-endoscope because they are very large in size along with their form. It is difficult to maneuver into the fundus. Understanding the anatomy of the varices as well as collaterals. Not only you require endoscopy, but you require a good fluoroscopy many of the time. The endoscopist has fear of scope damage because of the glue, and expertise are limited. In esophageal varices, the first study of description of the feeding vessel comes in 1990, followed by in 1996 from India, Dr. Gauradas Chaudhary. And in 2000, Lahoti has published 5 patients where what he did was EUS-guided perforators was targeted. And what he has shown that the 2.2 sessions to achieve the obliteration of varices with no recurrence of bleeding for 8 to 12 months. So the first therapeutic intervention of EUS-guided vascular intervention come in 2000 by Lahoti in GI endoscopy, where 5 patients, the perforator was targeted, and they shows that the recurrence of bleeding was not there in those group. After 6 years, the Di Paolo published his paper again in GI endoscopy. It was an RCT of 48 patients And he compared EUS-guided sclerotherapy versus endoscopic sclerotherapy. And the number of sessions until eradication was 4.3 in the EUS group, that is 1.5 EST group, versus 1.2 in the EUS group. So that study shows that presence of the collateral vessel was associated with the recurrence, and less and delayed recurrence was ES group because he targeted the perforators. So EUS has some role in the management of the esophageal varices. Then Irisava has also published the paraesophageal collaterals and perforators can targeted within EUS, and that may lead to the less recurrence, less bleed in cases of the patient who has already eradicated varices, but they again presented with the GI bleed. You target the perforators, so these are the paraesophageal varices. This is the EG junction, these are the perforators. So in the nutshell, because the data is very scanty, I think the treatment of choice for the esophageal varices is still bending and the EST, but in a patient who has a recurrent bleed, EUS may be useful. We require more data. When we talk about the gastric varices, not comparable to esophageal varices because they are different. Gastric varices even can bleed at the low portal hypertensive pressure. They are associated with the high mortality and the rebleed rate are also very high. And the incidence of the gastric varices is up to the tune of 1/5 to 1/2 of the patient when start from 1 year to 5 years when you follow up. So a sizable number of patients has a gastric varices. And we know that endoscopy is the current standard of care. But if the endoscopy fail, then it goes to the IR in the form of BRTO or patient may require TIPS. The question comes, what is the place of EUS? EUS is gaining its importance, but still in infancy. The question comes, why endoscopic glue fail? You look at the real-time scenario. There is a torrential bleed and the entire fundus is full of blood and your vision is obscure. Many of the time patient has eaten the food and the fundus is full of food. You cannot visualize and you keep on changing the patient. You keep on elevating the head and patient keep on bleeding and many of the time patient dies. Severe bleeding obscuring the vision. You cannot target the perforator vessel. It is still a relatively a semi-blind procedure. You don't know the adequacy of obliteration, risk of embolization, and the incomplete obliteration is very high. So I think endoscopic glue therapy, as it is cheaper, easily available, that's why it is more acceptable, but it is not the definitive way of treatment. We don't have any other alternative modality which appears superior. There are few studies comes with the EUS, but my personal belief, because this modality is available from the last more than 20-25 years, that's why it is in our blood and we say this is the standard of care. But there are flaws. We don't know the adequacy of obliteration. Many of the time patient has a torrential bleed, food is accumulating, and there is no complete obliteration. We cannot see that we have done the complete obliteration. We only assess the bleeding has stopped. That means we have tackled the fundal varices. I think that is not scientifically true. So why EUS? Because it is an extension of endoscopy in the same room. It is less invasive than IR procedure. It is less costly than IR procedure. You can know about the anatomical detail. You know that these are the intramucosal varices which needs to be targeted, and these are the perforator which do need to target them. Endoscopically inevident varices or the actual size of the varices you may be able to see within EUS. The perforator can be visualized. The real-time obliteration like we saw yesterday, you real-time you know that yes, I have done the job. Many of the time when you do the EUS-guided puncture and you do the obliteration, if the part of the varix is still competent, then you can redo the procedure in the same setting and you can sure that yes, you have done the complete obliteration. Yes, it is costly than endoscopy, but it is cheaper than the IR related procedure. What equipments are required? I think majority of us are using the linear echoendoscope, therapeutic linear echoendoscope, but forward viewing echoendoscope is also useful, especially in the fundus. it is useful. The commonly used needle are 19G, but 22G needles can be used. Glue and butyl cyanoacrylate is available in India, but rest of the countries, the people are using N-octyl cyanoacrylate glue also. And the endovascular coil from the Cook Medical, they are also of a great help. Now, the forward wing echo endoscope, this has an advantage. It is easier to intubate, easier retroflexion in comparison to the linear echo endoscope. It has a water jet facilities, a wider channels, and optics in the field of vision is less, but there are certain subgroup of the patient where I think the forward wing echo endoscope is very useful for obliteration of the esophageal varices. The glue properties and type, yesterday I discussed, but again I will re-emphasize. We have an N-butyl cyanoacrylate which is available in the India and the Bangladesh and the Sri Lanka. The disadvantage with the N-butyl, it is the rapid polymerization 4 to 5 seconds. So in our practice, we use the lipid oil. It increases the polymerization time and it helps in visualization under fluoroscopy. So the clogging of the needle will be less. N-octyl cyanoacrylate glue, it has a polymerization time of 15 to 20 seconds. Mixing with the lipid oil is not recommended. Easier to inject, low risk to the scope, no premature catheter plugging, lower risk to the personnel, no risk of needle sticking to the varix. So N-octyl cyanoacrylate glue, in my opinion, is better. But if you don't have, then mixing the N-butyl with the lipid oil in 1:1 solution is preferable. Now, this is very important. Which solution to be used? Because when we use the lipid oil, when we flush the needle, when we inject the fluid, which fluid is better? So this is the study which was from the Dr. T.S. Chandrasekhar from Chennai. He has published in DDW 2016 and he used 5 types of solutions. 5% dextrose, half normal saline, distilled water, normal saline, and the tap water. And he makes 3 different manufacturers of the cyanoacrylate glue, 1 ml of each. And what he has shown that 5% dextrose in the distilled water were found to be most compatible pre-filling and flushing the liquid medium with all 3 types of glue preparation. So this is important that whenever we are planning, then rather than using the saline, we should use the distilled water or we should use the 5% dextrose. Various coils are available in the market. The coil diameter ranges from 2 to 20 millimeter. If you are using the coil of less than 10 millimeter, then the 22G needle is sufficient. But if you are using the coil of more than 10 millimeter, then it is better to use the 19G needle. The coil length is available in 10 to 200 millimeter. And it will depend upon the number of the loops. Up to the 7 centimeter coils, the 2 loops are formed and 140 millimeter 4.5 loops are formed because the loops indicate about the diameter of the varix which is going to be covered by the coils. So what is the coil? These are the synthetic strand attached to the metal alloy. So look at here, the coil is coming out. This is a 1 loop, 2nd loop, and the 3rd loop is there. Similarly, you see here, there's a coil embolization. So it is very important, those who are doing the EUS-guided coil and glue, they make sure that the size of the coil should be adequate. If you are using the smaller size of the coil, risk of embolization will be very high. Now, EUS-guided injection route. As I said, EUS linear echo endoscope, it is not possible to retroflux. So you always use the transesophageal through the crush or directly through the stomach, you are puncturing the fundal varix, but the transesophageal route is more convenient. The reason is that there's a linear echo endoscope, you are directly visualizing, no disruption of the gastric mucosa over the varices, and it goes through the crush of the diaphragm, so the stability of the needle will be better. But the problem with using the transesophageal route, you have seen yesterday, those patients who has a large esophageal varices, you are going through the varices and the risk of bleeding will be very high. So if you are tackling the fundal varices, please make sure that if the esophageal varices are large, try to use the transgastric approach or use the forward wing scope rather than using the transesophageal approach. Now we have 3 things EUS-guided glue injection, EUS-guided coil injection, and EUS-guided coil followed by the glue. So what is the concept? When you are using the glue, it is an extension of endoscopy. The advantage is you are directly injecting the glue into the collaterals as well as perforators, so less amount of glue is required, but still there is a risk of embolization. And it is difficult to find out the collaterals many of the time while doing the EUS. Coil remains larger than the diameter of the varix, which I have discussed 1.2 times. Less risk of embolization, but you may require multiple coils and the cost of coils are high. If you use the first coil and followed by the glue, I think this is a win-win situation. You are using less number of coil and you are using the less amount of glue. So when you use the less number of coils, the cost is less amount of glue, risk of embolization will be low. And the concept is coil act as scaffolding, which I'm going to show later. So the first conceptual study is given by Romero Castro in 2007, where in 5 patients, he used the glue into the perforators. And what he has seen that 100% hemostasis is achieved, no rebleeding or other complication, produce a maximum blood flow blockage of the inflow with the lower amount of cyanoacrylate glue. So what Romero Castro done in 5 patients, he injected the perforators and each achieved the hemostasis in all 5 patients. Another study published by Gulbar, and what he has seen that the large single center study over 7 years, 36 patients out of 40 were treated either at the time of bleeding or within 24 hours of bleeding. Histoacrylate injection was done. And what he has seen that 6 out of 40 patients need an alternative rescue treatment. Rest all patients are treated with the endoscopy EUS-guided glue injections. So active bleeding of the gastric varices can be treated successfully with the EUS-guided injection of the histoacrylate glue. So patients who are actively coming to the casualty with an active bleed, you can do EUS-guided glue and the coiling. But the complication of the glue I have already discussed. There is a risk of embolization and thrombosis. Yesterday, the case also you have seen there is a collaterals was also getting thrombosed, but the pulmonary, cerebral, and the cardiac, you see here the glue was migrating into the lung, and these are the CT which shows the glue cast. If it is large in amount, the patient might have a death on the table. So I think using the glue cautiously is very important. But all patients of fundal varices are not the candidate for the glue and the coiling. This kind of picture that is called as carpeting, especially in a patient of splenic vein thrombosis, these patients are not suitable for the EUS-guided glue and the coiling. You just require is a bunch, a large bunch, which is a suitable candidate. EUS-guided coil was first again reported by Romero Castro in 2010. And he has shown in 4 patients, target the perforator, eradication was achieved in 75%, but the problem was number of the coils used was much higher. In one patient, 2, another patient, 5, 7, and 22. So you see the cost of treatment goes very high. So number of coils, I think will be decided by the size of the coil which we are going to use. This is the study which was published in 2013. And what they have compared the EUS-guided cyanoacrylate glue and the coil. And the conclusion of this study was the complication was more in the glue group in comparison to coil, but the cost of treatment was much higher in the coil group. So because of this, to reduce the complication and to reduce the cost of treatment, the concept of coil before the glue came. And what was the concept? Coil provides scaffold to retain the glue. And the glue is not going to embolize. So less amount of glue is needed, less number of coil is needed. That is a concept. So first inject 1 or 2 or 3 coil depending upon the size of the varix. And then you inject slowly the glue and the coil will engulf the thrombosed glue, and that is useful to prevent the embolization because entire glue cast will be scaffold inside the coil. So this is by Yasir Bhatt, 2016, 152 patients, mean follow-up for 432 days. What they have shown that 5% of the patient was an active hemorrhage, 70% as a recent bleeding, and for 26% of the patient, they use as a primary prophylaxis of the fundal varices. Total coil was 1.4, glue was 2 ml, 80% obliteration in the 1 session, 90% obliteration in 2 sessions, 10 patient as a rebleed, and adverse event was negligible. They were in the form of minor bleed, post-procedural pain, and 1 patient as a suspected embolization. So 152 patient followed up for more than a year or so, and 80% in first session, 90% in 2 sessions achieved the obliteration. And what is the coil insertion technique I've discussed, but I will again insert the finer points. Use conventional echo endoscope to first visualize the varix. Use all protective equipment by the performer, because if the glue spilled, then it can produce damage to the eye. Puncture the varix, confirm the blood return. That is very important. And once after return of the blood, you make sure that you flush the needle, fill the gastric fundus with the water to facilitate the visualization, fill around 100 ml of the water, use Doppler to delineate the anatomy, use the coil as guided by the varix diameter, insert and lock the coil introducer on the FNA hub, advance the coil into the FNA needles, remove the stylet and introducer, reintroduce the stylet to avoid the coils, advance the coil. So this is the thing. I always do the first endoscopy. You see a large bunch of the fundal varix with the small varices here. Confirm that varix is patent. It is not obliterated by the previous person who has done. EUS was done, and you can see the large bunch of the fundal varix. I'm going to introduce around 100 ml of the saline of the water into the fundus for the better obliteration and knowing about the mucosal aspect of the varices. So you see here, this is the gastric lumen. This is the wall of the fundal varix. This is the fundal varices. This is the gastric lumen here. Now, these are the collaterals, large collaterals. Avoid puncturing these collaterals. No point in injecting the coil and glue in these collaterals. You always inject the intramucosal aspect of the varices. So these are the varices which needs to be targeted. These are outside the gut lumen. These are the perforators. So your intention is to inject this. The diameter of the varix was measured. So this is the both longitudinal and the oblique diameter was measured. The 19G needle was attached to the scope hub, which is already primed up with the 5% dextrose or distilled water. I puncture. Confirmation by drawing the blood. You see that by giving the negative suction, the blood has come to the syringe. Flush again the needle because blood is inside the needle. Then attach the coil. Introduce the stylet for 15 centimeter or 20 centimeter, because the coil is if you are using the 2 centimeter size coil. Then reintroduce the stylet. Make sure that your scope is straight. At the later portion, you see you are facing the little bit of the difficulty. So your scope should be in the straight position. And once your coil is inside, you can see under endoscopy as well as fluoroscopy, this is the first coil came. And depending upon the need, you can introduce 2 coils or 3 coils. So I think this is the, once we deploy the coils, this is the second coil which has come. And they produce the turbulence of the flow, reduces the blood flow. And once you know that you have injected adequate amount of coils, the next step is injection of the glue. This is the 1 cc of the siloacrylate glue with the lipid oil. And you gradually introduce, don't try to flush very fast, but gradually you inject 2 cc of the distilled water, and you see the glue has come, which is scaffold in the coil and retain. And this is the post-procedure Doppler application. You see a part of the varix is still patent here, but you do after 2 weeks or so, or next day, you see the entire varix has shrunken in size and completely solidified. So don't try to over-inject, that is important. In ectopic varices, it is useful. This is one of the example. You see the patient has a superior main obstruction. You see the carpet of the vessel in the duodenum. Patient was torrentially bleeding, and this was endoscopic glue application. 6 ml of the glue. The patient is still bleeding because the collaterus was very large in size, and the varix was still patent. So in these situations, they cannot be managed with the endoscopic glue. They always require coil, and we change our scope. We introduce the coil, and after introduction of the coil, we injected the glue, and you see the size of the varices has reduced. And rest patent varix we injected endoscopically because it was difficult to maintain. But this is a post-procedure CT. This is a pre-procedure CT. A carpeting of the varices which has completely gone. So coil and glue are also useful in the ectopic varices. So the last 1 or 2 slides, what do we have and what should we have in the vascular therapy? What do we have is EUS-guided methods are feasible and safe. Combination of coil and glue is preferable than either alone, as it should be decrease the cost and complications. But what should we have? A good RCT comparing with the endoscopy. In current scenario, my feeling place of EUS is recurrent variceal bleed despite endotherapy fail, poor candidate for TIPS, especially child C cirrhosis, advanced decompensation, not suitable for interventional radiology because of the portal vein thrombosis or ESPVO, hemodynamically unstable patient, limited IR expertise. In future, it may be used as a primary therapy of the fundal varices, TIPS. Some problem is originating. I don't know what is coming, but TIPS, EUS-guided intrahepatic portosystemic shunts. The animal studies are there, and they have the 2 studies we have done in the 10 and the 5 porcine model, and they were able to successfully do the TIPS technique as well as measurement of the portal venous pressure. I think portal venous pressure measurement, the Cook is coming up with their manometer. You inject with the 25G needle into the portal vein and hepatic veins, and you measure the pressure. That will be a very good method for knowing about the hemodynamics. So to summarize, ladies and gentlemen, EUS-guided techniques are safe. What we were worried in the past that we have to avoid the vessel. Here we are going to puncture the vessel and doing the endotherapy. Real-time obliteration can be achieved. Visualization of perforator possibly decrease the risk of rebleeding. Coil before glue reduces the risk of embolization. EUS-guided vascular therapy is evolving. A good RCT comparing with the endoscopy is needed. I have not discussed the pseudoaneurysm or so because I will be welcome to answer. Thank you. Thank you for the patience hearing. Thanks again to Dr. Vinay.
Thank you, sir, for the excellent talk. There are some questions. So one question from Dr. Vaishali. Your experience in rectal varices, sir, will be there in the live. I'm asking certain questions from the audience.
Am I audible?
Yes, sir, you are audible. Can you hear me, sir?
Yeah, I can hear you.
So there are certain questions from audience. So first question is, any experience with rectal varices for EUS-guided interventions?
So in my personal opinion, I have not done rectal varices EUS because it is very easily visible endoscopically. Endoscopic wise glue injection was done sometime, but I don't have a personal experience of EUS with the rectal varices, but this can be done.
And another question is, should we identify the upstream of the varix by EUS to see the perforator to perform the EUS-guided intervention, or just find the largest optimal varixes?
Yeah, it's a very good question. And I think that is the need of an hour. This I always feel. And I discuss in many conferences because it is very difficult to find out the inflow and the outflow collaterals. But Romero Castro has published his paper and he has targeted the perforator. My gut feeling is if we inject at the site of perforator, not that, then the possibility of using the coil.
The watch is okay.
But in my day-to-day practice, I still use the large bunch of the varix, which is in my practice. But I agree theoretically, if you target the perforator, that will be better.
And another question is any value of anchoring the coil across the perforator to prevent the migration?
Yeah, this has been shown, and I was showing also yesterday. So the two concepts are there. One is, if you see the varices as compartments. So what it might do in my practice, because many of the time the varice is 3 centimeter. You don't have a coil of 3.2 centimeter or 3.3. You have a maximum diameter of the coil is 2 centimeter. So what I do, I make one loop in the one compartment, second loop in second compartment, and third loop in third compartment. This is my thought process, no evidence. And the pupil has leave the part of the coil into the mucosa also. That is to prevent the risk of embolization of the coil. But conceptually, if you are using the coil bigger than the size of varice, the possibility of getting the embolization will be very less. Because if you see the varice, if you are using 2 centimeter of diameter coil, the collateral will not be 2 centimeter. So the coil is not going to migrate through the collaterals. So choosing the adequate size of the coil is very important, rather than thinking that I'm going to anchor either into the mucosa or I'm leaving the part of the coil in the one compartment or second. I think choosing the right size of the coil will be better.
Thank you so much, sir. There was the last question. Any particular tip while releasing the coil?
Your scope should be in the straight position. That is most important. I will tell you, in the duodenum, I've got a patient where the D3, D4, there was a varice and a try keep on doing. The coil was not coming out. Either use a smaller size of the coil or try to keep the scope in the straight position. Once the scope is angulated, then it is difficult. In those situations, better to use a forward wing scope rather than using the linear equilateral scope. That will be my thought process on this.
Thank you so much, sir, for the excellent talk and your expert views. So now we'll be moving to the next session of live demonstrations from Ideal Care. And we'll meet Dr. Vinay Dhir in the OT room. First, we'll be showing one live case, followed by there will be demonstration of US magic box, where he'll be demonstrating all the interventional US procedures.
Can you hear me? Can you see me?
Yes, sir, we can hear.
Okay, so welcome to Ideal Care on this Sunday morning. Before I start, let me introduce you to my staff, my friends, my colleagues who have come today on a Sunday morning to be with us. So Dr. Dharudkar is my senior anesthetist. He takes care of my patients while I am busy pushing the scopes here and there. Deepak on my right side, he is my right hand. He does all the work patient related. Bibin, my chief GI assistant, he helps me with the wires you must have seen in other conferences. So he does 50% of the work that I show you. Dr. Rahul Shah, my colleague, you have met him yesterday. Dr. Priyanka in the corner, if you can see her, you have been seeing her. Dr. Aruna, the director of this place, and my wife, she's also come on a Sunday morning to keep an eye on me. Julie, my chief nurse here, and there are some others outside. So these are all people who I pushed them to come today on a Sunday morning. So thank you all. Thank you very much. So today we had planned 4 cases for you. There was one biopsy, one Vaughan, a Nagi stent, one biliary drainage, and one GJ. But all these cases have been shown so fantastically yesterday by Rajesh and Sandeep. There is nothing left actually for me to add to whatever was shown yesterday. So what I decided is I'll show you just one very basic case of anatomy, and I'll show you the biopsy, and then the remaining time which I have 1 hour, you must have seen in the program with all the live shows I have kept EUS magic box. But because there were so many cases yesterday, we could not show the magic box. So for 1 hour, I will teach you on the magic box, the various procedures that were shown yesterday. So let us start with the first case, very basic case. And I'm going to just teach you anatomy and biopsy, nothing much in interventions that way. Should we start? So this is a young boy. Priyanka, you have the case history?
Yes, sir. So he's 35-year male, 4 weeks of abdominal pain. There was no history of fever or weight loss. There was no history of jaundice. And ultrasound showed some lesion in head of pancreas. And CT showed there was heterogeneous lesion in head of pancreas, uncinate process involving neck and body of pancreas. And tail is little atrophic with the dilated PD in the tail. CBD was normal. Amylase lipase was in 250 and 350 range. Calcium profile, lipid profiles are normal. There are small multiple calculi in gallbladder, and there's no history of alcohol intake. IgG4 and CA 19.9 is awaited. And LFT was completely normal.
Okay, thanks, Priyanka. So can you see the endoscope? Can you put the endoscopy image, please? I will start from the very basics. Put the endoscopy image half. Yes. So introduction of the scope. I will start with the introduction. You see, this is a linear 180 series echo endoscope, and patient is under propofol sedation in the left lateral position. We introduce the scope gently, and as you know, the scope tip is longer than our normal gastroscopy and ERCP scopes. As soon as I introduce, I start using my up control so that the scope slides over the back of the tongue. Once we have reached behind the tongue, I depress my up down control, see, like this, and I reach the cricopharynx. So you can see the cricopharynx here. Once you go to the cricopharynx, you should find the esophageal inlet gently by probing. Don't force ever. Once you have found the esophageal inlet, just insert your scope and you are in. So we are in the esophagus. Can we see the EUS, please? Can you see the EUS pictures? You see a lot of air here. So continuously use suction. You will have certain suction artifacts. So when a patient has come with an abdominal pathology and does not have any obvious mediastinal pathology, I like to just trace the esophagus in a sagittal manner. So you see here, freeze. I have rotated my scope in such a way that you are seeing both the walls of the esophagus. You see, this is the muscularis propria on one side. This is the muscularis propria on the other side. And this is the lumen of the esophagus. See this? So I quickly go like this, little anti-clockwise. I am at the neck now. Little anti-clockwise, little up, continuous sucking, and I create a tubular vision of the esophagus. Like this, you see there is a lot of air in the esophagus. Sometimes you may need to use the up-down control, keep it down, and keep a tube of the esophagus. See this? This is the tubular view of the esophagus. We are going down. I find this method extremely useful for a quick evaluation. See, now we are coming to the lower esophagus. You can see the gastric rugal fold. So we are coming to the GE junction. See this? This is the GE junction. Freeze. Pakado. So this is a beautiful view of the GE junction. You can see all the layers of the GE junction wall. So small lesions can be picked up. And this is the diaphragm. You can see the diaphragm here. So exactly you can see a sagittal view of the GE junction. See this? I'll show you again. This is the stomach. Come back. You can see the diaphragm here. You can see the liver on one side and aorta on the other side. And you can examine the GE junction really, really well. See this? This is the GE junction. Examine it. If there are some small lesions, some small veins. So like this, quickly evaluate the mediastinum also. So you see here, this is the mediastinum. I'm quickly examining it. So if you need to see something really, you may need some balloon or 2 to 3 cc's of water, but it gives me a much better view of the mediastinum on both sides, and quickly I can evaluate that there is nothing. You can see the diaphragm, freeze. So this is the diaphragm, see here. This is the diaphragm. So this is exact position of the GE junction here. Chodo. You can also see the neck vessels. You can see the AP window and other things by this method very quickly. And if you are doing a lymph node staging, I find this method superior to the traditional method, which only gives you anterior view or a posterior view. You have to rotate your scope much more in that method. Endoscope, once I am in the GE junction, I depress my up down and look if there is any fluid. If there is not much fluid, I continue. Otherwise, I suck the fluid. I don't want my patient to aspirate. So this looks okay. So we come back. EUS, please. Now, once I am at the GE junction, what I do is I start turning gently clockwise. So you see some vessels here. You see the liver here. See this? This is the liver. We come back. We come back. This is the fundus. We rotate, look at everything, and you see the hepatic vein. See this? So this is a clockwise rotation. This is the middle hepatic vein. You go a little more down, turn a little more clockwise, and you start seeing the portal vein. Freeze. So this is the hilum, and this is the portal vein. So there are many methods. All of them are good. There is no preference. Whichever method you are used to, please use that method. But I'm just showing you the method that I follow. Here, freeze. So here you can see what is happening at the hilum. This is the hepatic artery. This is the portal vein. And this is the bile duct. So we can measure it. 4.2 millimeters. So CBD is normal. That means there is no obstructive pathology in the CBD. I already know before reaching the papilla. CBD looks very normal. Then I try to push my scope down. And sometimes your scope can get stuck in the fundus. So if that happens, what you do is push your scope in a little more and then turn clockwise, and you are seeing the pancreas. See, you are seeing the pancreas with the lesion straight away. So this is the liver. You see this? You can see the left lobe. You can see the segment 3, the left hepatic vein. Turn clockwise, and you see the portal vein again. Please. So here is the portal vein, and here is the bile duct. This is the edge of the pancreas here. So this is the bile duct before entering the head of the pancreas. And this area, the white area, is the duodenal bulb. So all this you are seeing from the stomach. We are not entered the duodenum as yet. See this? We are tracing. Either you trace the portal vein or you trace the bile duct. See this? Now we see that there is something in the head. Freeze. Immediately I know, because I cannot trace the portal vein fully here. See this? There is something here. Let us see. Chodo. So I am just 4 centimeters 5 centimeters beyond the G junction. And you see this portal vein is getting stopped by a lesion. See this freeze? So this is the head of the pancreas. Here, you can see this is the C loop of the duodenum. This white air is the C loop of the duodenum, head of the pancreas. This is the portal vein, and it is, you see, it's narrowed here. So there is a lesion which probably is causing obstruction to the portal vein. Chodo. And this lesion is, you see, I'm using extreme up now to see what is happening. Please. So, little knowledge of the anatomy. This is the portal vein coming. This is the splenic vein. So, if you see the neck of the pancreas, this pancreas is also not normal. It appears edematous, heterogeneous, and bulky. So, even the neck and body region doesn't look normal. See this? We go again. We go again. I'm turning clockwise. Portal vein. And then that is the splenic vein. Sorry, I fell over the spine. So the scope suddenly turns above the spine sometimes. See, that is the confluence, please. So here, portal vein, superior mesenteric vein, splenic vein. The nice thing here is, if you see carefully, there is a hyperechoic wall all around the portal vein and the splenic vein here. So at least on this side, there is no involvement by whatever mass this is of the confluence. This is called as the confluence. Very important area if you want to stage tumors. Chodo. Again, I do the same thing. See, I'm turning clockwise with my right hand, and you are seeing this bulky head, and you are seeing the confluence. And now I turn gently. Oh, again I fell. Yeah. Now I'm turning gently clockwise, withdrawing, and I'm seeing a fluid-filled area. This looks more inflammatory, probably a pancreatic fluid collection. See here. So this patient was supposed to be having a malignancy. This looks to me, first shot, a very inflammatory lesion. Doppler. You see, this is our pancreatic duct here. We are now gently turning clockwise and withdrawing. This is the splenic vein. See, the splenic vein is taking the blood. And then I don't see much pancreas beyond this. Actually, he's a young man. So I should see a lot of pancreas in this area. We are still at the level of the kidney. I'm withdrawing still. You should always examine all the way till the spleen. You can see freeze. This is the left adrenal here. Chodo. You can see the bird-like appearance. Left adrenal. We turn clockwise, more clockwise. And if you see my right hand, I'm really turning the scope now with my right hand. You reach the spleen. You have reached the spleen, and you can see the splenic vessels entering the splenic hilum. Now I reverse, turn anti-clockwise to see if there is anything I have missed. So repetition of the same thing. Try to bring the splenic vein. You see the aorta has come. I am still turning anti-clockwise, tracing the vessel. More anti-clockwise, and you see the abnormal area. See this? So it looks like a bulky head of the pancreas with a bulky neck and body, and there appears to be a fluid collection kind of thing here. My first impression would be pancreatitis, although surprisingly, there is no history of any significant pain. You see the splenic vessel underneath? It's nicely coursing underneath. There is no problem here. some free fluid, very small amount of free fluid. So this all information we have got from the stomach. Now let us go into the duodenum and see whether we are correct. Endoscope. Endoscope. So you see this, all this information is from the proximal stomach. Now we confirm it by going into the duodenum. Amylase lipase, by the way, was normal. So maybe he had some pancreatitis long back. Now we are seeing the residual. So I am in the bulb now. Let us see the EUS. So this is the pancreas. You can see the pancreas. It looks in normal. This portal vein. See this, please. So I turn clockwise to see towards the papilla. Portal vein, splenic, superior mesenteric. Dikhao. This is the head of the pancreas. Now let us examine it in detail. Here I am seeing the fat planes nicely preserved. So this is a classic picture you must have seen in many books. Portal vein, common bile duct, head of the pancreas, confluence area. This area is the neck and body. This is the head. This is my duodenal wall. See this? This is the duodenal wall, muscularis propria. Chodo. So let us examine. Thoda bada kar do. So it is abnormal. It is not a normal head, no doubt. But if you see the fat planes, here I am not so sure whether they are involved. Little more sedation, please. Yeah. So this is the head. You can see the bile duct coming. Ask me, I will think it is an inflammatory process. Please. There is some lymph node here in this area. So if you turn clockwise, you see more toward the ampulla. If you turn anti-clockwise, now I am turning anti-clockwise, you will see more toward the hilum. So you see the bile duct going, it's perfectly normal bile duct. See this? I am tracing it up towards the hilum and you see the gallbladder appearing. Even the gallbladder is having sludge. Freeze. See here, gallbladder has lot of sludge. So this all process, chhod. See this floating material, there is no shadow. So these are not gallbladder stones. This is sludge. Now we are reaching the hilum. See this, this is the hilum. Looks perfectly normal. There is no problem here. Segment 6 here. Again turn clockwise. And you see the head. I actually don't feel like biopsying the head. It looks pretty okay to me from here. Yeah. This is the head. So probably this is not a mass, and I think this is an important information that we are giving to this patient because doubts were raised whether this is a malignancy. Endoscope. Then you go to D2. Be very careful going from D1 to D2 because that is an area, if you are beginning your EOS, you can perforate. So do it completely under vision. And then withdraw just like how you do with your ERCP scope and put the EUS back again. EUS. So I don't use a balloon. Normally you have to turn a little clockwise to see these big vessels, but here I'm seeing it straight away. See, this is the aorta with the common iliac vessels. I'm coming, now I'm withdrawing. This is the IVC. Little clockwise, aorta. Little anti-clockwise, IVC. Underneath, you can see the spine. So I'm coming back very slowly. Very slowly. Now I'm turning my up control also. And now with my right hand, I am using a clockwise torque. So millimeter by millimeter, use a clockwise torque and you will start seeing the head of the pancreas. So this is the clockwise, see, extreme clockwise, and this is the head of the pancreas. See this? I don't see any tumor here. We carefully see everything. We draw still further. Sometimes it will fall into the stomach. So don't worry, you can go in again. But if you are too worried, you can use a balloon. You can see the pancreatic duct here. If you want to see the papilla, you need to put in some water in the bulb to see the papilla. But here we are getting a nice view of the complete head of the pancreas. I am gently withdrawing now. Little clockwise, anti-clockwise twist so that you examine the entire pancreas. Like this, slowly, slowly. Keep withdrawing. See, it looks bulky, but I don't think there is a mass here. Clockwise, anti-clockwise, clockwise, anti-clockwise, millimeter by millimeter, complete examination of the head. You can see the ducts, see, Doppler. See, that is the pancreatic duct. Please. So, if you can see, I don't know whether you can appreciate, this is the main duct, this is the accessory duct here, they are joining here. So this is the pancreatic duct. Looks okay. Mildly hyperechoic edges. Chodo. Pancreatic duct. If you look little above that, you see the bile duct, which also appears normal. It doesn't look abnormal. If you want to see the bile duct, you have to turn anti-clockwise. You see the aorta underneath. Aorta underneath means uncinate process. IVC, keep withdrawing. There is a lymph node here, as I showed you before. Looks reactive to me. Now I withdraw to the stomach. So control over your scope is very, very important. See, now I am back into the stomach. And you see this area. I think this is all pancreatitis. And I will just probably, I don't know whether I should sample, but because there is a question mark over malignancy, we will sample this area, which looks like a well-defined area with cystic components. So we will sample this area, Doppler. If you want to sample any area, bring it at 6 o'clock, 6 to 7 o'clock. I will use a Acquire 22 gauge needle. So if you have a area which has both solid and cystic component, then you should try to aspirate the cystic content and take biopsy from the solid part. And always give antibiotic because you may end up infecting the cystic, the fluid part of it. So yesterday, Rajesh and Jahangir beautifully showed you the biopsy. What we do is, if you can see here, as was explained yesterday, there are two buttons. First, we use the lock for the sheath. We open the sheath, push it a little forward till it is seen on your ultrasound. Not too much. You see here, you can see the sheath now. See that it is moving at the top of your ultrasound screen. Then you release the lock. As Rajesh explained yesterday, I use my middle finger. See, this is my middle finger as a lock. So I don't use this lock, middle finger, and with the thumb and index finger, I first gently take out the needle to see what is the trajectory of the needle. See that blue mark, you see the trajectory of the needle. This looks okay. Sometimes from the stomach wall will go in. So your jab should be quick. See, we are in, we push in the stillet a bit, and I always use a slow pull technique. I never use any other technique. The double door and door knocking and all those are nice. So remember, once you have gone in one direction, don't go in this direction again, because once you have gone in a direction, the needle goes in and comes back. It creates a very minor empty space, which is always filled with blood. So change your direction, go in another direction. See, I went in another direction, and as I'm withdrawing, Bibin is withdrawing the stillet very slowly. Then I try to use my up down to go in another direction. See here, then I go in another direction. Then like that, 4 or 5 different directions you choose using your up down. I'm satisfied with what we have got so far, and we take it out. The needle is out, we put it at 0, lock the controls, and then I do a Doppler quickly to see that I have not created bleeding somewhere. See this, you can see some vessels here. So observe, because sometimes the patient will go home and then come back with bleeding. So observe the area, looks okay to me. There's no major blood spurting happening anywhere.
There's one question.
Yeah.
From Dr. Nikhil. Will elastography will help in this situation?
In this case, no. It's an inflammatory thing, but we can, does it have elastography? I think I have an older version here, but I will not do elastography in this case because it doesn't look malignant to me at all. But if there is something solid, then yes, elastography may be used. In my personal opinion, I am not an expert on elastography. I feel it is too subjective. The objective criteria are not there. So same lesion, you can create malignancy or inflammation depending on how much pressure that you put on the tip of your probe. So my personal feeling, but of course, literature tells us that elastography is good. So if you have a solid lesion where you are not sure what you are dealing with, here because of the rim of fluid, I am pretty sure we are dealing with inflammatory mass. Have we got something good? Huh? So in the last 2 years, I have never made a second pass. A single pass doing like this gives me enough material. Yesterday also you saw both Jahangir and Rajesh got good material in the first pass. We get nice white cores, and we do not have a rose facility. So we just put everything in formalin and send it to our pathologist, and we get good results, 100% results in all the cases. So this is all very basic thing I showed you. I hope this has been useful.
One more question.
Yeah.
Can it be autoimmune pancreatitis?
So there is a possibility that it could be autoimmune pancreatitis because there is a bulky head. We are not seeing the pancreatic duct very well. So yes, it is possible. We will do an IgG4. It has not been done. So the primary thing, everything went towards the direction of malignancy. The moment the CT scan was reported as malignancy. So we will now do an IgG4. It's a good idea. Yes, we should think of autoimmune pancreatitis.
And one question from Dr. Rawal. Is this slow pull technique is the best?
Yes, no doubt. See, there is a lot of things going on in the EUS biopsy, and I like simplicity. And for me, I do one technique and I stick with it. I don't go here and there, try 100 techniques. If you are focusing well on the lesion, if you are doing good fanning, you will get good tissue. There is no other way about it. All the suctions and all those things, I think, are more for literature, and they were of an era when you used FNAC. So you were not sure whether you are getting a tissue or not. Now, I only use 22 gauge biopsy needle. I don't use anything else, and my results are pretty good. So I tell everyone, it's not very expensive. Use a 22 gauge biopsy forceps. Concentrate on focusing at the lesion. It should be in the right direction, and fanning, very, very useful. So you should fan the lesion, take from 4, 5 multiple areas. Don't take from the same area again and again, because then you create bleeding and you will get very, very good results, I can assure you.
So one more question.
Yeah.
Do you think contrast enhanced harmonic EUS helpful for differential diagnosis and guidance of FNA puncture site?
Yes. So in certain cases where you are not sure, you have done a biopsy and the biopsy has come negative, and there are necrotic areas within the lesion, you want to know which is the viable area within the lesion. So for such cases, contrast is useful because it will light up the viable areas because they are vascular, and then you can target your biopsy in that direction. So the thing is, most of my patients do not have insurance. I have to think of cost. So contrast only to be used in patients in whom you are confused. You do not know where to take biopsy from. And then yes, it is useful. Once you use a contrast, you will pick up these areas and you biopsy target those areas. Elastography, I am not a good fan, but contrast, yes, it is useful in select group of patients. So next we move on to the model. I will show you the model that we have created. So just give me 1 minute. I'll move to another room and see you in 1 minute.
Thank you, sir.
वो इतना ऊपर दिखाएगा तो कैसे? इसको थोड़ा ऊपर करो, ये दिखेगा नहीं बराबर मैजिक बॉक्स। Okay, can you hear me? Can you see me?
Yes, sir, we can hear you.
Okay. So, voice is duplicating. So, this is innovation that we created. As you know, at the Ideal Care, we have a school of EUS, and we teach EUS very actively. I started doing interventional EUS, I think in 2008 or 2009, and very soon we realized that the number of cases, even at big institutes, are not enough to train people in the details of the procedures. So since then, we associated an Asian EUS group was very kind to help us financially and otherwise. And last 7-8 years, we have been working to create a model for interventional EUS. The first model that we created was a 3D printed model, and it was just a basic 3D printing image of the bile duct, and we used a liver, pig liver, and we showed the basic steps of EUS-BD, and it was very much appreciated, the model. We published it in GI endoscopy, but the model was very basic, so many things could not be done. Later on, we realized that 3D printing, the material is pretty stiff, and we are not finding a solution to have a material where we can puncture, dilate, place a stent. So we shifted to hybrid models where we had a silicone tubings and mixture of stomach and duodenum. And our second model was also specific to EUS-BD, and we could do CDS, Rendezvous, antegrade, and other procedures in that. This is the third innovation in that same series, because as we go on, we learn the mistakes. So one problem with that model was it could only be used under fluoroscopy. So we needed some model which could be used without fluoroscopy. So it could be used in conferences also. The other thing was we wanted multiple interventional EUS procedures in one model. So this is what we have created. We call it EUS Magic Box. We have already tested it in 2 conferences, and our trainees find it pretty useful. If this was not a COVID-19 pandemic, you all would be here learning on this model. But because of COVID, I cannot call you here. So I will show you what this model is. It's not a very difficult model to make. You can make it yourself if you want, because you have to understand, if you like interventional EUS procedures and if you need it in your department, you have to start learning. And learning hands-on is going to be difficult because there are not enough cases in most centers right now. So it is better that you prepare yourself with the basic steps by using a model. There are multiple other models also. Asian EUS group has been pioneering. So Professor Kida has created a very nice model. Some of you must have used for CDS and HGS. The Thai group has created a very nice model. And I think Anthony has a very nice model for gallbladder drainage. So learning on models is the way to go. And that is why this magic box is being created. So what this magic box is, basically it's a box, and to avoid fluoro in all cases, we have put a camera at the top here. You can see this is a toggle by which we can move the camera. Can they see this? दिखाओ जाओ इसको छोड़ दो अभी उधर दिखाओ. So this camera looks inside so that you can visualize what you are doing without using a fluoro. of course, you can use the fluoro by removing the top of the box and do fluoro assisted procedures also. So you can see this as I'm moving. This is the model inside. You have the esophagus here attached to an inlet, 2-3 centimeters. Then you have a pig stomach, cleaned, sterilized, disinfected. The duodenum is closed. If you see here, the duodenum is sutured. We have removed the duodenum. Instead, we have created an artificial duodenum. So if you see this big tube on the right side, this is a duodenum. You see here, it is a C of the duodenum here. And we have created holes on top of the duodenum so that you can see what is happening inside. Next to the duodenum, you see the papillary complex with bile duct and pancreatic duct. We have purposely created a very easy model. So the bile ducts are hugely dilated, pancreatic ducts are hugely dilated, so that it is easy for us to learn initially. But of course, we can create tubes with more complex, narrower bile ducts with multiple strictures and ultimately that is not very difficult. Underneath this stomach, you can see gelatin. This is the gel that we use for ultrasound. And then you can also see that we have put cautery here. So cautery can be used. And underneath you have pseudocyst and you have biopsy. So multiple procedures can be learned on this one model. You can do EUS-guided biopsy, simple procedure, pseudocyst drainage, EUS-guided BD, biliary drainage, EUS-guided pancreatic duct drainage, and you can also do practice gastrojejunostomy. So you see this duodenum is going deep inside, and we have kept a tube here to fill it with water. We can also put a balloon to give an impression. Yesterday you saw Sandeep showing beautifully. So we can inflate a balloon to stop the flow of water from going forward, and we can do axial stent placement. So this is the model. I will show you how it is from inside, the EUS images and everything. So Bibin has worked very hard on making this model for us. He's there since morning, 6 o'clock, making this model. So it takes about, if you have ingredients, it takes about 2 hours. So you see this, there are 2 holes on the box. One is for the duodenum, the black one, this one, and one is for going into the stomach. So this duodenum, first I will show you. If I go into the duodenum, this is our duodenum. See here, these are the holes. See this? If I go in further, you see, this is the duodenum. And here we have created a huge papilla. So this is not like a normal papilla. This is just for practice. So you see the pancreatic duct opening, massive pancreatic duct opening. And above at 12 o'clock, you have the bile duct opening. So this is a papilla here. You can do rendezvous with this. This is a duodenum that we have created. And if you go into the stomach, now I'm going into the stomach from the other hole. So this is the esophagus, and we start the EUS. Let us see what we see. Are you getting the EUS picture? So you see, you are seeing this tissue, which can be used for biopsy. You can see there are ducts. This is the bile duct. See this, please? Somebody has to come and help me with the scope. So this bile duct, you see, it has very thick walls, and it's a huge bile duct. See here, this is the lumen, this is the wall, this is our needle. So we can practice the position of the scope, the puncture, passage of wire, passage of stent, All those things can be practiced here. So let us start with a biopsy. I showed you a biopsy in a patient, but here you let us see how it is. See this? This hyperechoic tissue. This is basically a pig subcutaneous tissue. So I'll put my needle here and I can teach you all the steps that I showed you from here. How to puncture, what direction to take. Same thing, how to take out the stillet. See, I am taking out the stillet now. You can see it here. See this? You can see the stillet. Release the lock. Then, chodo, bring it close. 6 o'clock or 7 o'clock direction. Pakado. And then try to see the trajectory if you are in the right trajectory. See? So first you should always check the trajectory and then puncture the lesion. See here, we are in the lesion now. Then I can teach you fanning on this. You can fan, see this, using the up-down control. So this is how I teach biopsy to my students. Very simple, very easy. So when you come sometime to our department, we can show you how it is. Then, of course, you can see the bile duct here. See this? So you have to learn how to bring it in position first before you puncture. Then you have to check under fluoro. If you are using the fluoro, is your direction of scope all right? Are you looking toward the hilum or you are looking towards something else? Once you are satisfied with that, you can puncture. So I am using a 19 gauge needle. So it is important to learn basics of how to keep the scope position, how to get a good scope position, and what works here. Again, we do the same thing. Use our, this is a Bosch Cook needle, EcoTip Ultra, to take out the sheath little bit. Yeah, we can see the sheath now. Then get it at 6 o'clock. See, get a good position first before you puncture. Then puncture a little to see whether we are in the right direction. If you feel that you are in the right direction, it doesn't look like very right to me, but let us see. Now you are in the bile duct wall, and then you puncture. You are in, you can aspirate or inject. Now we are injecting a blue fluid and you concentrate on the bile duct. You know, you on the mirror image, you can see the image. We are injecting. See that? It is filling. You can see it is filling well. So we are in the bile duct. Now you should practice passing the guide wire. You can use a Terimo or you can use a VisiGlide because here the bile duct is very, very wide. So we are going to use, what are we using, Bibin? Okay. So we are using a HydraJag wire. You will see the problems of wire shearing like real life. You will see how to manipulate the wire. Practice a lot of things on this. What is the exact time? 11:54. Ah, lot of time. So Bibin is passing the wire and we will be guided by this image. You can see in EUS, you can see the wire coming out. See this? See that? See the wire is coming out. Now he has to pass it in the direction of the bile duct. He could be passing it in the opposite direction also, we don't know. So he will manipulate a bit and see whether the wire, of course you can use fluoro. I'll show you fluoro also later on. So what he is doing is he's pushing it. This is not a good wire to use here. See, there is a problem. So these are real life problems. Use a Terimo. Don't use this. So always use a wire with a floppy tip. So how to see that the wire is going in the right direction? So these are all steps that are very important when you are learning EUS-BD. Yeah, so he's again injecting some contrast to see that we are in position. Of course, on the EUS, you can see that we are in the right position. So now he has shifted to a Terimo. Let us see whether it helps us. So getting a good position, needle puncture, and then wire passage. These are the things you have to learn. And I suggest that you learn it initially on model so that you are perfect in rotating the wire, in knowing where it goes. So Bibin is now trying to see. My view is obscured a little bit because I think air has gone in. So can you see the wire? I think, yeah, you can see the wire. The wire is at the papilla now, very nicely. Come back. So there is a stricture at the papilla. You see, it has come out from the hole. So again, negotiating through the distal bile duct papillary complex is an art that you have to learn. And then again, you will see that the wire shear very easily if you push too much. So small amount. So Bibin got excited. He just pushed too much and now he's stuck. He cannot do anything to it. So these are all the steps that you have to learn. See, the wire is stuck now. So it'll shear. See, the wire is come out. So these are all the things which we need to learn. I'll puncture again. This is just to show you that things, when you see with the experts, sometimes things look too easy. When you do it yourself, there may be problems. And it is important that we practice a lot. Yesterday, we showed you a model of the guide wire manipulation. That model is also very useful. You use that model to learn how to rotate your wire. So that is also very important to learn wire manipulation. So you or your assistant both should learn how to rotate the wire. If we have a difficulty, of course, fluoro to get us the right direction. So here is the needle. Can you see the needle on ultrasound? See, I am in the bile duct wall. I am in now. We can also include vessels in it, blood vessels. So if you are worried about hemorrhage and other things, थोड़ा डालोगे, हाँ? एक साथ इतना सारा मत डालो.
There's one question from audience.
Yeah.
Any tips on reducing shearing of the wire?
The only thing you should do is you should not push too much of wire. What happens is suddenly you get excited and you push too much wire. So use millimeter by millimeter. Don't put too much of wire, because if you go in a wrong direction, withdrawing the wire will cause shearing. So that you have to remember. Other thing is, if you have to withdraw it, just don't withdraw it very fast. Change the angle of the needle a bit, maybe withdraw the needle a bit, and that may allow the wire to come back. But sometimes shearing does happen, and you have to be aware of that. So to avoid it, never pass too much at one go. Go slow, always. And that is the way to avoid shearing. So these practical things are very important. Now you see the wire coming. Where is my needle? Is it in still or not? It is in. So on ultrasound, I am checking whether my needle is in or not. Is your wire out? Abhi aaya nahi hai. Abhi aaya. Yes, now ghumao. So you can see the wire coming out from that hole. So you have to rotate gently there. And there is a narrowing there at the papilla. So to go through the papilla is a big challenge. So we are trying to rotate, put it inside. Bibin is rotating the wire. Because it is a terumo wire, it is not very visible to him. So he doesn't know which direction it is taking. So maybe a fluoro, a different wire, something needs to be done to visualize, improve the visualization. बहुत सारा डाल दिया तूने अभी फिर से. हाँ? Yeah. क्यों डालता है इतना सारा? So see, problems. We all have to learn these problems. Be patient. Okay, नहीं आ रहा है ना? Well, see, there is a narrowing there. So it will not go beyond until it enters from there inside. Otherwise, it will go on coiling there just above the papilla. Right? No, नहीं होने वाला है. Withdraw नहीं होएगा ना? नहीं होएगा. So again it is stuck. So let us use fluoro. Fluoro लगा सकते हैं. We'll use fluoro now. I hope you are not finding all these things boring. To me, it is very interesting because challenges are what make the whole procedure interesting. So, and these are real challenges that you will face when you start doing interventional EUS.
So Dr. Raval is asking which wire we should use, Termo or VisiGlide from beginning.
We love Termo, but VisiGlide is equally good. So we use a J-tube Termo. Don't try. नहीं जाएगा. नहीं. देखे तो सही क्या हुआ है फ्लोरो में. थोड़ा सा इसको खिसकाना पड़ेगा टेबल को. So we are putting a fluoro. Give us 1 minute. बिबिन को पहले पहना दो फिर मैं पहनता हूँ. Hold. वो टॉप निकालो उसका. So now we are removing the top so that we can do fluoro. Fluoro, please. हाँ, ऊपर ले. दिखाओ. ना, वो ठीक था. और थोड़ा सा. और थोड़ा. बस. So you can see the pancreatic duct below. हाँ, दिखाओ. You see what is happening to the wire now? See this. We are in the bile duct and the wire is coiled 1,000 times inside. Yeah. So it's an irretrievable situation. Pakado. So fluoro helps. If you use a wire which has markings, you know, the Boston Scientific wire, 035 wires, Metro and other things, then
You can see it here. The Terimo wire is entirely black, and we have used methylene blue. So that is why he is not able to visualize anything, and he is finding it difficult to pass it through. A fluoro always helps. Now, a third puncture. This is a needle. Let me see if this is coming in direction. Get a good direction. Okay. Flush a little. Yes. So you see the scope direction is good. It is going just towards the hilum. And we can of course always change direction now that we have fluoro. Scope को 12 o'clock पे ले लेना. घुमा थोड़ा. No, other way. Or. Yeah. You can see a part of the sheared wire where I have punctured. So if you want to change the position, fluoro, and you are not happy with it, you rotate it. See, I am rotating the scope, pushing it a little so that it is in a better position. See this here. So this is how you do in real life also. If you see that the position is not good, change the scope of the position of the scope so that it comes towards the hilum always. Then passage of wire becomes easy. Now Bibin is trying again. You see how much wire is sheared there? A full wire is sheared, complete. आया नहीं अभी. नहीं आ रहा है. पकड़ो. हाँ. Wait. See, it went in the opposite direction. So now Bibin has to rotate so that it goes towards the fluoro. See, it is going in the periphery. So we have to use a J-tipped wire and then rotate it. Yeah, that is how it should go. You see, he rotated it. Now it is going towards the hilum. Follow the wire as it is going down. What happened? Is it come out? No. जाओ. जाने दो. Push. See, now he is putting slowly. Stop. नीचे दिखाओ. नीचे. Now see, there is a narrowing there. So he has to rotate the wire again so that it enters the right area. नहीं, वो edge है. Center में आने का. हाँ, अभी जाओ थोड़ा सा. नहीं, edge पे है. ना. So, needle withdraw. ले. Now you are in. Beautiful. See? Go नीचे दिखा. ऊपर क्या दिखा रहा है? अरे. See, now you are through the papilla. उधर दिखाओ ना. Push. Now we are into the papillary complex. Now we are out. You can see. Tip दिखाओ. Beautiful. Yes, now we are deep into the duodenum. Now what I will do is I will withdraw the needle. While Bipin is feeding the wire. And if you can show Bipin's hands on the camera, he will, because this is a short wire, he will use the water installation method to retrieve the wire. So these are small techniques. Nikalu? I can see the wire on ultrasound. He's also checking intermittently on fluoro. Now you see, can you see Bipin's hands? The wire is finished. So he's putting a syringe there and he's flushing saline with force while I will withdraw. Fluoro? Nikalu? So now you see how fast I can withdraw this, and it is out. Very, very useful method for short wires. Now what I will do, I will withdraw the scope and put in the ERCP scope. Okay. Nikalo dhire dhire scope. Fluoro. धीरे 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 क्या कर रहे क्या कर रहे निकल गया क्या? So, you know, these things are very challenging and we really learn every time we do a procedure. So we have done this. Now I'll pass the ERCP scope and try to show you how to catch the wire.
So one question from
Yeah.
Dr. Benjamin.
Yeah.
How long would you as an expert try EUS-guided BD in failed cannulation before resorting to IRT?
So normally it doesn't take more than half an hour, Benjamin. We, I think, are now pretty sure, and I don't remember when my EUS-BD has failed last. So, but I would normally, for any endoscopic procedure, not try for more than 30-35 minutes. If it doesn't happen, it doesn't happen. And probably you know in the first 10 minutes that it is not going to happen. It's like ERCP. When we started learning ERCPs, we were trying for 2 hours and all those patients will have pancreatitis. Now we have guidelines not to try more than 5 minutes. And I think that makes sense because frankly, you know in the first 10 minutes whether you are going to succeed or you are not going to succeed. And trial beyond that only creates more problems. It doesn't. So I will say 30 minutes is the upper limit. Probably 15 minutes also you can say, no, yeah, this is not happening. Forget it. Now I am passing the scope. This is an ERCP scope. Show the endoscopy view, please. You see, I showed you the duodenum. So this is to practice rendezvous. See, this is the wire coming out from the bile duct. So position your scope properly. Pakdo. Yeah, so this is the wire. You should always hold it a little away. Don't come too close to the papilla, otherwise it will just slip in. So try to hold it a little away from the papilla. That is always the best. So I'm using a snare here. You see, this is my snare. Now we will try to get a good position. Sure. Aisa, pakado. Open the snare a little. Open, open, open. So like this, you open the snare and try to catch the wire. Now withdraw the wire millimeter by millimeter. Am I on proper side? Like this, you try to catch it. Slowly, slowly, slowly. Withdraw, withdraw, withdraw. Slowly, slowly. Close. You saw how we caught it? Now that you have caught it, you can do two things. One, you can bring the wire within the biopsy channel like this. And many a times it slips. It's a very slippery wire. So while the wire is being fed by Rahul from one side, I am slowly trying to withdraw. See this? It's a very cumbersome process. So normally we leave the wire there and try to cannulate by the side when we are doing rendezvous. So like this is the exchange process. See this? Once the wire comes out of the biopsy channel, we can use this wire to cannulate. So we are trying this. Let us see if it works. Sometimes it slips. If it slips, we can always try the other methods. So when you are withdrawing this, you should always remember, see, it has slipped. You should not have too much tension on the wire. So just go a little bit below the papilla so that, you know, the wire comes out smoothly from the papilla, and somebody should feed the wire from the mouth so that we are doing a smooth exchange. So this is why you see rendezvous is not a very popular technique, but I love it because it is the least, it is the most risk-free actually. It has least complications. All you need is a 19 gauge needle to puncture and a wire. That's all. And you're not dilating any tract, you're not causing bile leaks. So if the papilla is available, rendezvous is a very, very useful procedure to do very fast. The normal rendezvous procedure may, if you are doing this method and not cannulating by the side, then this procedure of pulling out the wire takes some time because we are doing it very slowly. We are not doing it fast. See this? Gently, gently the wire is coming in. I'm withdrawing. Until it comes out, you are not sure whether you caught it or not. So it's a slow, laborious process. See this? Gently withdrawing. If you are too fast, it will just slip because it's a very slippery wire. Remember, Terimo. So some people don't use Terimo for this reason. It can slip anytime. Aa raha hai ki nahi aa raha hai? Huh? So I'm withdrawing. I think I have withdrawn quite a lot. It should come now. Dhire, 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 dhire. Everything has to be slow, methodical. Aa raha hai kya? No, don't feed too much. You're feeding too much. So you see, coordination between all of us is extremely important. How much to feed, how much to bring in, because it may coil in the duodenum and then it becomes a little difficult. At the same time, it should not be too small to, then it comes out from the top or oh, wow. You see here, show the camera please, on my hand. Can you show my hand? Show my hand please. Yeah, see the wire has come here. Once we hold this wire, hold it tight, open the snare, and now we can put a sphincterotome over it. I will withdraw a little more. Is there enough wire? So I am withdrawing this wire. See this? So that a sphincterotome can pass over it, and then you can complete your ERCP. This should be enough, I think. और निकालना है? और निकाल सकते हैं. ले. हाँ. So now Bibin is threading a sphincterotome over this wire. You can see that. What is the time? No, this is not working. This is nonsense.
The time is 12:20.
So we have only 10 minutes. I have to show lots of procedures. I can show you GJ here. I can show you pseudosis. But anyway, you have seen that in real life. We didn't show you a rendezvous. So
one question.
yeah.
What if you pull too fast and the wire grasp slipped? How to troubleshoot it?
Yeah, so if the wire goes, flush करो, flush किया अच्छा? नहीं, अंदर जा रहा है. Flush किया कि नहीं? Flush is most important. Flush करो. So with these hydrophilic wires, you need a lot of water. So if your wire slips, then what you do is bring that wire. So slowly keep putting the wire out while withdrawing your scope. So it will come somewhere in the stomach, grasp it again and go in. But this method we use in only about 20% of cases. In vast majority of cases, once the wire is out of the papilla, we cannulate with the ERCP scope by the side of the wire. So this bringing the wire into the scope channel is a traditional method, good method, but cumbersome method. It takes time. So better thing is, you see this wire coming out of the papilla. So put your sphincterotome by the side and cannulate. अंदर जा रहा है तो बड़ा ले लेना 7 French dilator ले ले जाने दो. Okay. So we are going in. I think some wire is also going in. Yeah, you see the sphincterotome? Now you are in the bile duct, and then you can complete your whatever treatment, stenting, stone removal. I find Rendezvous a good procedure in those rare cases of CBD stone where you cannot cannulate. This is of course very easy, but Rendezvous in benign cases is very, very useful. Like this, you can do a pancreatic rendezvous also. You can pass in the pancreatic duct. See, so this is a rendezvous procedure for you. Now I will, in 5 minutes, quickly show you the other areas. I will not do any other procedure. So this model, we plan to use it, make it better for more complex procedures and use it for ERCP training also in the future. EUS scope lagao. I will just show you the various things that we have attached here, which will, the multiple procedures apart from EUS-BD. So in this, we can do an antigrade, we can do a HGS, we can do rendezvous. Choledochodiornostomy, a little difficult, but that also can be attempted. We can do a pseudocyst drainage. We have attached a pseudocyst here, and we can do EUS-GJ. So almost all the relevant procedures, vascular therapy we have not included. It can be included without much problem. Gallbladder drainage can be included in this, should not be a problem. So I think we have found the base for a single model for all interventional EUS procedures, and further refinements will help us improve our training very much. So again, I'll go into the esophagus. EUS, please. So you see here, this is the pseudocyst. So we can again show you how to puncture, how to do an axial stent. Now there is no time, Bibin. Para 25 ho gaya na? So this is the pseudocyst, nice pseudocyst we have created for you. If you want to learn, this is a pancreatic duct. See that? We can do a pancreatic duct therapy here. We can teach you pancreatogastrostomy, pancreatic rendezvous, and somewhere we also have the GJ. Where is the jejunum? सीधा जाना पड़ेगा. ये है ना? ये है ना? हाँ, I can see your tube here. See, this is the jejunum. Please. So we can teach you how to place an axios for GJ. In this, we have a tube. Pani dalo tube mein. We put a tube there so that we can instill water, which you can see here. डाल रहे कुछ आ नहीं रहा है. बंद है ये तो. Your tube is not working. Is it working? और डालो. हाँ, अभी आ रहा है. डालो. Can you see the water coming into the duodenum? और डालो. Another 2 minutes and I'll stop. So this is the water filling. You fluoro दिखाओ. You see, I am on the jejunum now. You can see this is the DJ flexure on fluoro. So we can put water in this. There is a tube you can see going through for water installation. And we can puncture here and teach you axial stent placement. So I think this is all that I have for you. Pancreatic duct, jejunum, pseudocyst, EUS biopsy, and EUS CDS. This is the pseudocyst, bile duct. I hope you enjoyed this. This was not on real patients. And I will just join you in 2 minutes if there are any further questions. Thank you very much for this is our hard work. We have been working on it continuously.
Hi, Matthew.
Hi. Can I share my slides? Okay.
Yeah. Priyanka,
Yes.
can you please introduce Dr. Matthew Philip?
So now the next talk will be on EUS-guided GJ, how I do it. from Dr. Matthew Phillip. He's Chief Interventional US Expert and Head of Gastroenterology at Lisi Institute of Gastroenterology, Lisi Hospital, Kochi. Welcome, sir, for the lecture.
Thank you so much. At this time, I would like to thank Asian EUS Group and Dr. Vinay and his team for this wonderful conference and the kind invitation. Last 1.5 days, I was virtually attending every session. And in fact, sometimes I was working and listening to this wonderful live demonstration. I was thoroughly impressed by the magic box. And I think it is a real boon for education for the students. And Vinay must be knowing that how difficult it was for us to learn in the past, going to different countries and actually looking at and learning ourselves. That was the biggest challenge. And now the students are so lucky and they have got so many things now to learn. So, gastric outlet obstruction. Now, relief of GU symptoms is very crucial, and this is mainly to maintain the nutritional status of the patient to improve the quality of the patient. As the general condition of these patients are quite poor and the prognosis is poor, we need to do a minimally invasive treatment. When you look at the gastric outlet obstruction causes, malignant disease predominate, but there are benign disease also. But mostly we are interested and we actually do endoscopic maneuvers like GJ in those patients who have got malignant disease. So coming to the management options of gastric outlet obstruction, we have surgery and then we have endoscopy. And surgery, am I audible?
Yes, Matthew, you are audible.
Surgery and endoscopy. Endoscopy, we have different options. So surgical bypass, the problem is the morbidity behind the surgery and survival of the patient may not be much, and to subject them for a major surgery may be difficult. Even if it is a lap surgery, sometimes they may not tolerate that. So what about enteral stenting? It's a nice option in those patients with a less survival or a short duration survival. But the problems with enteral stenting is stent migration, obstruction, overgrowth, and ingrowth of node. These are all negative points. Dilatation is being done only in benign diseases and has got variable results and multiple sessions are required. So coming to EUS-GJ, it has got many advantages. It is minimally invasive and there is usually no stent obstruction. So what are sites of obstruction where you do, where it is indicated or contraindicated? Those lesions in the distal part of stomach, like the antropyloric region or in the duodenum, especially in the first part, second part, or early third part, we are able to. All other portions like body of the stomach, first part of jejunum, or DJ flexure, fourth part of duodenum, all makes it difficult to do this procedure. So coming to the indications, I believe malignant gastric outlet obstruction for palliation is the most common indication. And then we have afferent loop syndrome, but whatever be, regardless of etiology and size of stenosis, symptomatic GU is considered to be a candidate for EUS-GJ. So coming to EUS gastroenterostomy, we know that it can be directed towards the duodenum or it can be directed towards the jejunum. And but for all practical purpose, I'll be using the terminology of EUS gastrojejunostomy or EUS-GJ, but it may be going to the third part of duodenum or it may be even going to the jejunum. So what are the key steps in EUS-GJ? The first step is actually to find out or target an area for better visualization of the intestine, a segment you have to visualize from the stomach. Next is you have to create a tract from the stomach to the intestine. And the last one is you have to establish a new fistulous communication between the stomach and the intestine. This is done by a combination of endoscopy, endosonography, and radiology. And in essence, it is obtaining an access from the stomach to the jejunum or the small intestine. So let us look at each steps. So the first step, visualization, requires fluid installation. It can be done by many mechanisms, like you can actually install with the scope itself, or you can use device assisted like using balloons, tubes, or nasobiliary drain tubes, etc. Or you can use even double balloons and fluid filled segment can be used. So for creation a tract from the stomach to the intestine, that is you get a needle puncture, guide wire, cautery tips, catheters, or balloon dilatation. For establishing a new physical communication between the stomach and you require a fully covered metallic stent, and that is the lumen opposing stents. But making all the second two steps in a single approach, you have got the electrocautery-aided lumen opposing metallic stents. So when you look at the patients who is selected for these procedures, the small intestinal tract intended for the stent deployment should be close to the stomach. So you can actually do a imaging to find out if not only for this assessment of roadmap, but also it will tell that there are many other lesions in the small intestine or distal obstruction is present or not. And if the stomach wall is involved more proximally by the cancer, you need to find out a safe puncture site. Otherwise, sometimes it may be even not possible because if there is extension into the body of stomach. And cancer extending in the fourth part of the duodenum, as I told you, or into the jejunum, then he is not a candidate for EUS-GJ. This is actually the CT scan showing there is a loop of intestine very close to the stomach. Here also you can see that. Here also you can see that. So this could patient, and there are no other major lesions or obstruction. So this could be a good candidate for that. The small intestine, how do you prepare this patient? Pre-procedural assessment with endoscopy and imaging is essential because they have got gastric outlet obstruction. Clearing of gastric contents may be very, very important. Otherwise, you may not be able to do the procedure on the day of the procedure. So you have to put these patients on clear liquid diet and soft diet if tolerated on the previous days. Nil by mouth on the day of the procedure, and procedure is always done under anesthesia, general anesthesia. And it should be done in an endoscopy suite with the fluoroscopy and EUS facilities. Antibiotics, the choice varies, but I usually give 1 shot of antibiotic prior to the procedure. Accessories and equipments is all standard. Your therapeutic unit has got everything. You need to have an upper G endoscope in hand, linear EUS, electrocautery unit functioning. It should be done in a fluoroscopy room. And you should overtube if you are, depending upon the type of accessories or type of technique you do, you need an overtube and guide wire. Guide wire is essential, and devices to fill the duodenum jejunum with fluid like double balloon tubes or NBD tubes or whatever it is, or other balloons. And what you require is saline or contrast or methylene blue or a mixture of all these things. And needles, 19 gauge needle, if at all is used, is optional depending upon the technique of what you use. Because of the new technology of EC lamps or lumen opposing stents in a single delivery system, this becomes less useful. So needles are very less commonly used. You may require a CRE balloon to dilate the lamps once placed. And lamps as such, you know that it helps to attach two adjacent hollow organs. And it is made of a alloy that has got a sharp memory. So it is a fully covered one with silicone membrane to prevent fluid leakage as well. So there are 4 or even now 1 more has come, 4 different types of lumen opposing stents. But now what we require is actually a stent which has got a single step procedure. It has got very good radial force. It has got excellent lumen opposing force and short saddle length that is between the flanges, and wide flanges and reasonably wide lumen to pass the food particles in from the stomach into the jejunum. So probably they all will point towards hot axios, which is probably a single step procedure or a electrocautery aided supported lamps that is more useful in this case. So when you come to the electrocautery enhanced lamps, EC lamps, it's a single device. It has got a delivery system with attached cautery wire or tip. It does the puncture, it does the tract dilatation, placement of stent, all in a single step. And this is the most commonly used technique, and technical simplicity and safety that favors when you use EC lamps. So coming to the type of axiostents or the stents used for lumen opposing stents, the EUS-GJ stent is actually a stent which has got a flange diameter of 29 and lumen diameter of 20 millimeter, and stent length, that is the saddle length, is almost 10 millimeter. And delivery system is 10 French. What are the contraindications of EUS-guided GJ? It's actually, as I told you, if the site is and the lesion is involving the body of stomach and tumor extending in the fourth portion of the duodenum or in the proximal jejunum. And it's similar to other contraindications for any therapeutic endoscopy. Or ascites is not a contraindication anymore because it's only a relative contraindication. But no, I think even if there is ascites, you can aspirate and then you can do the procedure. So the techniques coming, there are umpteen number of techniques coming. But everything, the basic concept is almost same. So you have got almost 6 techniques now. That is the direct one which came was first, then retrograde, rendezvous, balloon assisted technique, directly puncturing the balloon. You can see that you keep a balloon inflated and you puncture the balloon and then perform the procedure over that. But the most commonly performed are the nasobiliary assisted technique or a double balloon technique. So this is what we are going to discuss on that. So EUS-guided double balloon occluded GJ bypass, that is actually E-pass, which was demonstrated by very nicely by Dr. Sandeep yesterday. And this is coming up in a big way, and that is going to be probably a very important technique of doing the procedure. And I will just go by step by step. There are 8 steps by which we can actually, what you do is an endoscopy. This actually slides given by Boston Scientific. I thank them for giving these slides. And it says endoscope with an overtube is advanced to the stenosis site. And then you pass a guide wire across that. You can see the guide wire has gone beyond obstruction. This is the model. And then you pass the E-pass tube, that is actually a long tube with the 2 balloons. And it is passed to prevent coiling inside stomach. You use the overtube. The overtube can be of single balloon or double balloon endoscopes. And once and the tube is the balloon that actually you find out the 2 balloons are, and once it has advanced beyond or located across the ligament of teats, that means your position is adequate. And the balloons are simultaneously inflated with the contrast so that it can be seen in fluoroscopy. And once that is done, you remove the overtube and leaving behind the inflated double balloon tube. Now you have to bring in your EUS scope, and you come there and start filling the segment of intestine or the portion of the tube with multiple openings. You inflate it, you instill contrast, methylene blue and saline in that so that it can be seen in the fluoroscopy as well. Methylene blue is mixed to find out that when you puncture, you have punctured the right segment or not. And it's the dilated intestine, the segment of loop of intestine, which is in between the 2 balloons, is detected by the EUS and then you try to puncture as a single step procedure by using Axios or a lumen opposing stent or EC lamps, whatever technique you use. There is actually a cautery enhanced tip is there, so that can deliver. Then the distal flange is delivered, that is deployed into the jejunum. Then you use the conventional technique of delivering the Axios stents or the lumen opposing stents, and then it is the distal flange is pulled back towards the jejunal wall, towards the gastric wall, and then you pull the scope back a little bit so that you can see the black mark well, and then the proximal flange is deployed gradually. So this is the technique of doing a double balloon E-pass technique, and this is the procedure is completed. So this is actually just to show you how the technique is being done again. Over tube, then you pass a tube, endoscope, guide wire, over the guide wire, E-pass or the double balloon tube, enteral tube, and inflate the tube balloons with contrast, and then you in between segment, the segment of bowel you selected is filled with the contrast and methylene blue and saline, and then you puncture and complete the procedure. So I think one of the most important technique or technical challenges is with the Axios stent or the lumen opposing stents you use. So the technique needs to be studied well, and yesterday I think we have seen that Dr. Sandeep has demonstrated very well. It is connected to a monopolar cautery system, and I'll quickly go through that. It is actually not exactly for GJ. What you see is actually the handle. It is pushed down. You go inside the cautery system. You go inside the bowel. You initially unlocked it. Now it is locked. And next step is actually, the second step is actually you remove the safety button, then move towards to open it up, pull the handle, so it is actually opened up there. Pull the scope backward, deliver the whole delivery system, so that is opposed towards the gastric wall. Lock it again, distal one, and last step is actually you deliver the whole stent into the one portion into the jejunum and another into the. So the issues with this technique is actually the double balloon EPAS technique tube is not commercially available. So you need to use alternative devices like nasopharyngeal tube or other systems or custom-made devices. So I will just tell our experience by using a custom-made tube. This is a tube made by in our department, which has got 4 lumen, and this is it. We have got it has two balloons at the tip, separated by almost 6 to 9 centimeters. And this is, you find out to do the endoscopy, find out the segment, area of stenosis, pass the guide wire, and then this tube, this is a tube as I have told you, sorry. And you pass the guide wire, and over the guide wire you pass the tube, inflate the balloons, and we have inflated with the air, you can see here, and bring the EUS scope, introduce the EUS scope, identify your bowel, and during this time you instill the segment between the two balloons with methylene blue and saline. We don't use contrast, but contrast is no problem, you can use it, and then you puncture it. And see under fluoroscopy, distal phalange is delivered, opened up under fluoroscopy, and once it is completed, we can see the methylene blue coming out. And once it is there, delivered, then we dilate with the CRE balloon to a size of around 12 millimeter, and you see the jejunum, and that what you see inside the tube, oroendric tube which we used earlier. So once delivery, and this is the balloon, and this is actually the stent, and we remove that. So coming to a video aspect of this, you identify a right patient, use an upper G endoscopy, clear the stomach and all, and then go to the lumen and find out the stricture site. Pass your guide wire. Sorry. Always better to use over a catheter so that the guide wire can be easily passed. Once it reaches there, you over the guide wire, you pass your balloon catheter or tube and pass it beyond the DJ flexure, inflate the balloon and secure position. Then you pass your linear EUS scope. You can see the oroendric tube there. Find out the segment filled with saline and methylene blue. Identify the best spot for your puncture, and it is better to measure and find out. Should have at least 3 centimeter, so that there won't be any problem in delivering your system. If you can actually get a segment like this, is the best, because there's enough space there, so you can delivery system can be well placed. Once you are punctured, then the distal flange is opened up. You can use the fluoroscopy here. Then it is pulled towards the, then it is pulled towards the lumen, which as we have seen there. Make sure that you are using fluoroscopy also to make sure that it is delivered properly. You start seeing the methylene blue coming out. That means your delivery system is correct. And once you reach there, once you delivered it, can you take out the EUS scope, use an upper G endoscope to pass a balloon. This is not done by many people, but some people does it. But I think it is okay to do that, so that you will make sure that the opening up of, and you can visualize it very well. So post procedure, what we do is they keep them nilorally for 24 hours. If required analgesics is given, they are maintained on IV fluids and observe the patient in the hospital for 24 to 40 hours. If there is no symptom, patient is sent home. And to make sure that we don't use it CT scan routinely, but just for a demonstration, I have shown that we can see the tube is delivered very well, and it is between the distal portion of body of stomach and just beyond the TJ flexure. So what are the outcomes of EUS-GJ using lamps? There are umpteen number of studies coming out, though the initial numbers are small in number, but now we have got meta-analysis, etc., which actually shows that almost all the studies have shown the technical success and the clinical success, and actually the rate of complications are less and the success is much higher. So if you look at the overall technical success is almost 93%, clinical success is 91%. Re-intervention is required in a small group of patients, but this is actually, when you compare with the new studies or the new informations, it is much less. Complications do occur. It includes peritonitis, perforation, abdominal pain, bleeding, and another important thing is the mal-deployment of the stent. So what's the future of this? We know that EUS-guided is a very nice procedure, but similarly there are so many other procedures coming up in the background. One is about the magnets, and then buttons and knots is coming in a big way. You make an opening inside and then go and do an anastomosis outside the stomach, bring towards the gastric wall and make an anastomosis. But I think EUS-guided GJ is a procedure with a great future. And these are different types of EUS-guided techniques as well, and magnets, knots, so many other these are coming out. So I personally think that EUS-guided procedures, especially using double balloon with a segment of distended bowel with liquid, I think this is a very useful technique for, and this is going to be very useful in the future as well. So we cannot take it for granted. So I think EUS-GJ is a novel approach that aims to provide sustained palliation of goo. EUS-GJ is an effective and a safe technique. And out of the 12 patients which we did with the new tube, we never had any complications. All the patients could be discharged without any complications. And potential to become an alternative to surgery and enteral stents in patients with goo. Basically because less invasive than surgery and a longer durability when compared to enteral stents. We have got enough data now to say this document, we can definitely say that this is yes, because the data is available now to suggest this. In the near future, EUS-GJ is expected to become the gold standard palliative treatment for malignant goo. That is my wish and hope. Techniques need to be standardized and made simple, because now there are so many types of techniques are available. And it is not being standardized. One center does free technique, another center use nasobiliary, another center use double balloon, and another center use the puncturing on the balloon. So I think this needs to be standardized so that we will be able to tell what are the clinical success as well as the complications. And it should be made very simple by one major leap. I think it's because of the electrocautery aided lumen opposing stents. My personal belief is that double balloon assisted techniques could turn out to be the safe and effective method in the future. I would like to thank all my colleagues of Lisi Institute of Gastroenterology, and my special gratitude to Prakash Sakarias, my Chief of Intensive Service, actually, who is behind making this tube and doing studies on EUS-GJ. And Gunashekar is our Chief Technician, who actually creates this and actually makes animal models. Though not equal to Bipin, I think this Gunashekar is also doing an excellent work for us. And also thank Boston Scientific for giving me these animation slides and videos. Thank you so much.
Thank you, Matthew. That was a wonderful lecture on evolving technique, EUS-GJ, very exciting technique. You very nicely showed the technique, the variations, the issues. There are some questions from the audience for you, Matthew.
Yeah, sure.
Dr. Benjamin Tharian from USA. is asking where can one get this double balloon EPAS tube other than in Japan?
It's actually the biggest problem. Actually, when we started, we were thinking of doing EUS-GJ for quite some time. Then when we tried with filling up water with water, what I have noted is that it goes into distant areas, and sometimes if your procedure gets delayed, the water will even reach the colon, and you will end up puncturing the colon. So I thought you should have a segment where it should be targeted very well, and that we know that Toei has created a tube. So we were thinking about how to create something similar to that, and we cannot buy that. And then when we made this tube, what we found that the passage time as well as the total duration of procedure is much less, and the length of the tube is much less. Length of the tube is only 120 centimeter, and the balloon size is only 3 centimeter, and in between it is actually around 6 to 9. So we are actually varied and found out it's almost 6 centimeters is sufficient to create. So your puncture mostly occurs in the DJ flexure, or just in the distal D3, or towards just after the DJ flexure. And
so
I
is
think
the tube up for sale? Are you selling it?
no, it's actually we have contacted a person who is going to manufacture. Then in that case, good.
Okay.
I
There is
think
one more question, Matthew. Suppose your axial stent is mal-deployed. It is not deployed properly. Can you pull it back and reload it and put it back again?
it can do. In if you look at the literature, there are some complications they have mentioned and how they tackled it. One is that you make if your department is capable of going and doing notes, immediately make an incision, go outside, pull it up, bring it back, and switch around all those things. Otherwise, what I think, it is always better to keep a guide wire if it is possible. If you are not technically well equipped, I think your experience is not that. Probably once you puncture, you put a guide wire. But I think once it is pushed outside into the hole, usually it happens is that the proximal flange is put outside the stomach. That is the biggest problem. It's a big challenge. I think the patient, if is not suitable for surgery, I think you can actually make an opening knots and then go and take it out. That is what I think. Otherwise, you have to go outside into the jejunum, take it out, and then suture both areas. I don't know. I think, what is your opinion? You are an expert in EUS-GJ.
We have done it in one patient. The distal phalange did not deploy properly. We pulled it out and put it back again, and it worked very fine. Only one case, so not much experience, but in one case we have done this and it was successful. This is a very interesting question, Matthew. The balloon catheter, this is from Hong Kong, Chi Wing Chow. The balloon catheter, with the catheter which is passing in your area of puncture, and you are deploying the stent, and suppose the catheter gets trapped in the axial stent.
Never happens.
Very interesting question. I like the question.
Never happens. Even if it happens, you just wait. Let it get gradually. When you pull and come, it will come out. It just never happened to us. We never had a problem.
Okay. And then there are questions about marginal ulcer development around the GJ site. How to deal with that?
See, for me, once you put the stent, we never look at that. Because you send the patient away to home, and only if they are symptomatic, then you need to look at that. And if there is a problem there, I think you have to manage it. I have never seen that, but you treat it with the PPI. They usually improve. They should improve. Otherwise, there is no major necrosis. They should improve.
Another interesting question from you, Tinkyo. Have you experienced buried stent syndrome? And if yes, what should we remove and what should we do? Very good question, huh, Betty?
I think these are very buried bumper. I have seen in PEG tubes. Actually, when the PEG tube is sometimes buried, and then I have gone and taken out. But this one, probably we have put only in malignant gastric outlet obstruction, and they may not survive for long. And our longest survival is 1 year, and that person is absolutely fine. And I don't know the answer that if it is there, I think, you have to dissect it and come out with that. And I think, endoscopic dissection techniques are available and we can pull it out generally, because, this stent is actually very good stent and stiff and it remains there. So to pull out also may not be a problem. But I tell you, one thing is very, very important. This is a technique where even if a stent goes into a pancreatic walled-off necrosis or cyst, you can go and bring it out, because you can dilate it and then go in. But here the steps of the procedure should be very carefully followed. You should actually monitor everything. There should not be any hurry in that, because any mal-deployment is going to cost you a lot. The patient, and sometimes you have to reoperate, and many times it becomes a difficult issue. So I think very careful procedure this should be. There should not be any hurry, and you should be very carefully watching each steps. I think, otherwise you have to be Vinay, Dhir and all, you can go and take out the tube, even if you mal-deploy.
A lot of praise for your talk. Expected everybody saying a very fantastic lecture, Matthew. We thoroughly enjoyed it. Thank you very much. Thank you for giving us your time on a Sunday afternoon.
No issue. Thanks a lot.
Thanks a lot. Thank you.
Flora, thank you. Nice seeing you.
With that, I think we have concluded the Train the Trainer course. It has been a fantastic experience for us, bringing it to you. It was only possible because of great help from all the friends. Matthew is here, Sandeep from AIG Hospitals, Rajesh Puri from Vedanta, Professor Mitsuhiro Kida. They all have contributed immensely. Not only their own whole hospital staff, their endoscopy staff, everybody has worked very hard, and my sincere thanks to all of those who participated in this. Big thanks to Asian US Group for giving us this opportunity of holding the Train the Trainer course. Big thank you to Flora. She is, as usual, very efficient, and she's very prompt with any problems, and just WhatsApp her and she responds in a minute. Thank you, Flora, for all the help. Thank you to Olympus. Is Kenny here? Thanks, Kenny. Is Dixon here? Thanks, Dixon. Thanks, Kenny, for all the help. Thanks, Arun from India. So, so you see, when a program like this comes well together, we all feel happy, and it comes together because there are lots of people trying to make it successful. And that's how I see it, a team effort from all of us. And I hope to see you in Mumbai next year for the Train the Trainer course. In the meanwhile, we are planning India EUS Summit in January in Mumbai. So you are all welcome. I hope it will become open and you can all join us here. And in your presence, we can do some more education and other things. Hi, Kenny.
Hello, Dr. Vinay.
Nice to see you. Nice to see you.
Yeah, me too.
Thank you. Thank you very much. Is there anything else, Flora? Any concluding messages?
No, but these 2 days course is recorded, so I will share to everyone shortly when it's uploaded, and also the photos is available on Facebook, and I will soon send out an evaluation form. So please fill it out. We would like to hear your feedback so we can do better. And thank you, everyone. Thank you all your time, and hope you guys enjoy it.
Thank you. Thank you.
Bye. Thanks a lot. Thanks.
Thank you.
Bye.
Have a good day.
Yeah.
Take care.